Thank you, everybody, for joining today. My name is Ivy Bourgeault, and I'm very pleased to be launching, along with many partners here, the Compendium of Roles in Team-Based Primary Care. So this is work that emanated from the Team Primary Care Training for Transformation initiative with many, many different partners. So I'm really pleased to be launching this today. As is customary, we would like to start with an Indigenous land acknowledgement. And so just really want to begin by doing that. We meet today on ancestral territory of First Nations, Inuit, and Métis people from coast to coast to coast. I'm coming to you from near Mitsun, Quebec, which is near Kitigan-Zibi territory, Algonquin territory. It's important that in addition to acknowledging territory, we need to also acknowledge that as settlers, we need to work collectively and individually to recognize past and continued effects of colonialism and racism on Indigenous families, communities, and knowledge systems through the Indian Act, Indian residential schools, Indian hospitals, and other systemically discriminating policies, practices, and documentation, which continues to this day. And that we affirm our responsibility as settlers to improve relationships between nations and actively seek greater understanding of Indigenous peoples and cultures in the communities in which we live, learn, work, and play. And so we want to have you join us in acknowledging and affirming this commitment, each in our own way, as well as through the Team Primary Care Initiative and in your organizations to move forward toward truth and reconciliation, guided by the calls to action in the TRC report. So as mentioned, we are very pleased to be launching this Compendium of Roles in Team-Based Primary Care. As I mentioned, I'm Ivy Bourgeault. I'm the director of the Canadian Health Workforce Network and was very pleased and privileged to be a part of the co-leadership of the Team Primary Care Training for Transformation initiative. I will provide some overview for the context of how this compendium emerged. I will pass to Dale, who will introduce herself and describe some of the work that she spearheaded that laid the foundation for the compendium. I'll then pass to Sophie, or Dale will pass to Sophie, who will introduce herself and describe the work that she led in terms of the template for the compendium and how we went back and forth with our different partners. And then Sophia will pass to Derek, who will then pass to Michael, who will then pass to Treena, chosen in alphabetical order. I was just reminded of that. And as co-authors on 3 of the compendium chapters will provide their experiences of this process. We really want to hear from you. There are many partners here who contributed chapters, and we want to thank them and acknowledge their contributions. So we will give you an opportunity to share your stories. Please feel free to ask your question in the chat. Please pay attention to the chat. Raha will be providing some resources there, as well as a QR code. You can also raise your hands during the Q&A period, and we want to have as lively a conversation as possible and want to hear from you in terms of where we can go next with this compendium. It's very important. This is a document that we want to be used and to build upon as an important part of the foundation. So this quote, highlighted by the other Ivy co-lead, Ivy Anderson, who I think is joining us. I think I saw her come in. And this comes from the Romano Commission of over 20 years ago. If healthcare providers are expected to work together, it makes sense that their education and training should prepare them for this type of working arrangement. And foundational to that is really understanding what everybody knows and is able to do. So this work came out of one component of the Team Primary Care Training for Transformation initiative, the Interprofessional Collaborative Table, which created a never-before forum and an enormously inclusive forum to align curricula across more than 20 different practitioners groups as a way to advance comprehensive primary care, enhancing knowledge of each other's roles and contributions in order for us within these practitioner groups to learn about, from, and with. And the about was really critically important. This is what we hope the compendium will prove. In brief, the what we would call the curriculum of the interprofessional collaborative table took a number of different steps, and this is not all of them, but first and foremost, we wanted to foster relationships and building and sharing of the different practices, tools, and methodologies across partners. Many of those around the table had projects, from the get-go of Team Primary Care. Some of them developed projects later on. And we're really excited to have our three speakers with us to talk about what has followed subsequently. We're exactly a year after the conclusion of Team Primary Care, which was March 31st, 2024. So building on those relationships, foster an understanding of the scope of practice, skills that various primary care practitioners have and can contribute to team-based primary care. And then through a variety of different sort of iterative conversations, identify a range of services that would be included under that, basket or envelope of what is comprehensive primary care to promote a sense of breadth and alignment and training. And we had just started to work on the alignment of learning objectives, core competencies, and accreditation standards across those different groups. And this is work that will continue. So Team Primary Care was a catalyst, and we need to continue this work. So just before I go to Dale, this was sort of the cogs in the wheel that described the different activities. So Dale took a lead in synthesizing what are different comprehensive primary care domains, and to look at those in different buckets. From there, we mapped the scopes and competencies to some selected domains, which were then drafted into initially one-pagers that then, begat the compendium entries. And as mentioned, the alignment of learning objectives is work that needs to continue. All right, with that, I'm going to pass to Dale to introduce herself and to walk through how she came up with these incredible primary care service domains. Over to you, Dale.
Thank you, Ivy, and nice to see familiar faces and new faces again after all the work that we've done with the Team Primary Care and the collaborative. And as Ivy said, the primary care domains came out of discussions with our team, and the Ivies were saying, so if we're going to work together as a team and really work towards comprehensive interprofessional primary care, what is it that we're actually doing? What are we providing together as a team? So this is the sort of the output from an international literature search, everything from WHO, from the colleges, various countries around. What is it that we are anticipating that team members provide together in the delivery of primary care? So as you can see, this is the list of domains that we came up with as part of the study. And then under each of these domains, we outlined what, in fact, next slide, Ivy, what are the service delivery components within each of those domains? And as part of the work with the collaborative, first of all, we presented these domains and had a fulsome discussion around comprehensive primary care. And then we had the collaborative met quarterly, and we assigned quote unquote homework to individual disciplines to write down and submit what services they provide under each of the domains. And then as part of our meeting, we had fulsome discussions among ourselves and in breakout rooms and sharing what each discipline or each profession does in terms of delivering chronic care or maternal and child health. And I think one of the things that's the most remarkable that came out of it was that no one came out who was unsurprised about what another profession that they had been working side by side with for sometimes years had as part of their competencies or part of the services they delivered. So as part of that homework, we had people submit and we started to develop a spreadsheet, and the spreadsheet grew and grew and grew in terms of what types of services each profession delivers under each of those domains. And so when we just decided, well, now we've got to pull this together in terms of a compendium. And kudos to Ivy and Sophie for taking this to the finish line. And I'm hoping that this document is used far and wide for people who are planning for teams and also implementing them on the ground. Over to you, Soph.
Thanks so much, Dale. And thank you all for joining us. It's truly been a privilege to get to know many of our project partners and to work with you as we put this compendium together. So my name is Sophie Myles, and I'm a proud member of the Canadian Health Workforce Network and co-lead of the Integrating Care Models Optimizing Scope policy theme with my colleague Gail Hallis, who is on the call today. Ivy, next slide, please. Thank you so much. And so through the collaborative table dialogues, it became apparent that many of those involved in the education of primary care roles are not fully aware of the education and training and regulated scopes of practice of other provider groups, as well as how these are or could be applied in practice. And this poses a significant barrier to optimal interprofessional collaboration. So pictured here is an overview of one of the compendium entries developed by each of the professional partners at the interprofessional collaborative table. Entries begin with a case study narrative of the practitioner's potential interactions with patients and their broader support system, such as family members, friends, or community members, as well as other health providers within or supporting a team-based model of primary care. We thought incorporating the scenarios was important to demonstrate how the information that followed applied in various practice contexts and environments to inform those dedicated to primary care training and practice reform about how each provider group might function and be incorporated within the team. The main text of each entry starts with introductory information about the provider group. Next, important details about the training, regulation, and scope of practice of each practitioner are detailed from a pan-Canadian perspective. Each entry then details the specific contributions that their practitioner group, either to the 3 illustrative primary care domains, maternal and child health, chronic disease management, and end-of-life care, or within the context of their team primary care project. Curating this information for the first time is a necessary foundational step, but is insufficient if it is not integrated into the training and knowledge base of all primary care practitioners moving forward. And I am pleased to now turn it over to one of our project partners, Derek Cassista from the Paramedic Association of New Brunswick, to talk to us about the emerging role of paramedicine in primary care, paramedicine's team primary care project, and the profession's inclusion in the compendium. Over to you, Derek.
Thanks, Sophie. Thank you, everyone, for joining today. My name is Derek Cassista, Deputy Registrar of the Paramedic Association of New Brunswick. Was brought into the TPC team, well, it's been a few years ago now. And my first recollection of the first meeting was how cold it was in Ottawa, and meeting all these familiar faces today is nice to do. So thank you to Ivy for pulling this all together years ago, and for keeping the team together. It's easy to do it once, but to keep us all herded together is noble. So thank you for that, as well as the IP team. And everyone involved, specifically for our paramedic project. Thank you to Dr. Walter Tavares from the U of T and his team for the work they've done in contributing. So you might be surprised to hear about paramedics being included in a compendium of primary care roles, because for some of us who are within the profession, we've been talking about this for years, but other members of the healthcare team may not be so familiar. So for us, it's an honor to be included in the compendium. And to see healthcare systems within Canada begin to evolve their practice and really modernize and catch up with what a lot of the European countries have been doing for years. So our specific project talks a lot about, it's called Impact, which is the really, it's a struggle to break this down in 2 or 3 minutes, but it's a mind shift of thinking about what paramedics do versus what you think they do. And when everyone thinks of a paramedic, they think that what we do is we go on 911 calls and we take people to hospitals. But what if I told you that was about only a third of what we do? And what we actually do is treat a lot of patients who are seeking primary care. So, shocker, we know that there's an absence of primary care delivery in our country due to a number of reasons for a number of years. And, you know, we are really feeling that. So, on the front lines of healthcare, in terms of paramedics, we're really feeling that. So, what Dr. Tavares's project brought us all together to do was to look at the current paramedic structure and how could we restructure paramedicine within Canada to better meet these needs, because we're not seeing so much an increase of 911 calls. What we're seeing is a lot more demand for primary care. So instead of just becoming the profession that takes people to primary care, why don't we become the profession that starts to deliver primary care in the locations where we encounter our patients? And that's a mind shift for all of us, because in my talks, since the emergence of AI, what I talk to a lot of people about is what your presupposition of what our profession is. And if you go to ChatGPT, whatever one you're familiar with, and you type in, generate me a picture of a paramedic within Canada, it will generate you a person standing in front of an ambulance, because that's traditionally what people and algorithms think what we do. So we have a lot of work to do to redefine that. And Walter's project was really about starting upstream within competency frameworks and beginning to ingrain primary care principles into how paramedics are educated. So that's the quick synopsis of what that is. And then I think where this really took off was when we were able to, at the same time, there's a project within the CSA for a new national competency framework for paramedics. And we were able to include these new interprofessional competencies into our national competency framework, which is now published and live. And I've asked Raha to share you a link to a paper which describes that new competency framework. And we're very excited to be able to begin to scale this across the country and begin to stand up these models and a new way of thinking about how paramedics can contribute within the primary care team, because we all know there's a lot of work to do. So I'm happy to answer any questions. If you want to shoot me an email later, I'm happy to help talk more about our specific role. But that's it for me for now. Right now, I'm going to pass you on to Michael Feraday from the RMTAO to talk about their piece in the compendium.
Thank you, Derek. And it's great to be here and appreciate all the work, as Derek has mentioned, that Ivy and her group has done. Going back well over a year, I think I've been part of this and understanding from almost the very beginning how important this work has been. The Registered Massage Therapists Association of Ontario, which is what RMTAO stands for, really felt it was important to be involved and step up and represent massage therapy in the compendium in order to bring attention on a national level to massage therapy and to a pilot project we undertook that incorporated massage therapy into a primary care integrated team setting, which was our project in the intercollaborative table. Massage therapy is perhaps less well understood for the role it plays in primary care, and as a result is underrepresented in primary care teams. The compendium was an opportunity to provide an insight into the education, regulation, scope, practice, and the roles and responsibility of massage therapy in primary care domains. And it was an opportunity to share less well-known facts about massage therapy in integrated settings. So it was very important to use this as an opportunity to stress, to share more extensively and more broadly the role of massage therapy. The pilot project that I alluded to embedded massage therapists into an integrated team-based primary care team. Then the results, now that the pilot has been completed, demonstrated that massage therapy was very helpful in the treatment, not only of joint and soft tissue injury and pain, but also stress, anxiety, lymphedema, and systemic issues. Patients indicated that they were not only very satisfied with massage therapy services, but more satisfied since having access to massage therapy. Patients surveyed agreed that massage therapy improved their health and well-being and reporting less pain, and that the inclusion of massage therapy helped them reach their goals faster. The majority of patients surveyed reported having seen their doctor or nurse practitioner or even other members of the health providers on the team less often. And so, in addition, patients often took less pain medication. The pilot project revealed that there is a need for health professionals to learn in a more formalized way about the roles each plays in an integrated team, both from the perspective of the massage therapists learning about the roles of how to integrate with other IHPs, but also from the reverse perspective to ensure that everyone respects each other's scope of practice and the contribution that each member of the team can contribute, which I think reinforces the value of the compendium and the importance of the work done by this group. The pilot project scored well on all aspects of the quadruple aim as well. And one patient, a retired nurse, admitted to never having had a massage due to the fact that she never had a benefit plan and was simply amazed with the results of her treatment plan. And we included her in a number of videos that we shared with the Ministry of Health in Ontario and other stakeholders here. Post Team Primary Care and the Intercollaborative Table, we were invited by the Ministry of Health in Ontario to submit a proposal for an expanded demonstration project that would embed massage therapists into a number of integrated team-based primary care settings. So we're looking forward to following up on the work that's been done, and we are very much appreciated the chance to be involved in this project and the Team Primary Care Table. That's sort of what I have to say and share. We're open for questions, and I think there's a chance at the end to ask some questions as well, but please feel free to contact me if you're interested in anything of what I've related, and particularly, the work that we've done with our pilot project. With that, I'd like to introduce Treena Klassen from the Palliser Primary Care Network in Southeast Alberta.
Thanks so much, Michael. I'm so honored to have the opportunity to share with you my particular narrative of the development of the TPC Compendium. From my perspective, life's full of some key moments, and they often only stand out to us in hindsight. I found my way to nursing school over 30 years ago, and during this journey, I heard about a document called the Alma Ata Declaration that emphasized primary health care as the key to achieving health for all and recognized health as a fundamental human right. I remember talking about primary care with my professors and classmates and being shocked that this concept was an obvious dichotomy to the acute care-centric education that I was receiving. I remember wondering why I wasn't seeing these concepts in action. I experienced the opportunity of graduating from nursing school at a time when, believe it or not, there were very few jobs in Canada. Consequently, I worked several jobs at the same time, including acute care, as well as both chronic and crisis community care. And a few things stand out to me from that period of my career. People in the community are very sick. People sometimes choose to live at risk. And sometimes people don't go to care. Care has to go to them. And then family physician clinics serve as a hub of healthcare for a large portion of the population. Approximately 2 decades ago, I had the good fortune to be offered a job where I started this new system of care in Alberta called a primary care network. This work offered the potential to bring the utopia of primary care to fruition. However, through my work with over 40 primary care clinics, I've come to understand that healthcare providers receive very little pre-licensure education in primary care, and they're often poorly prepared to work in intercollaborative teams. Further to this, they typically don't understand their own scope of practice, nor each other's scopes or roles very well. In 2019, the Canadian Family Practice Nurses Association spearheaded the writing of national competencies for registered nurses in primary care. This was a huge step in the right direction, but we recognize that the competencies are at a high level and there's limited uptake of them throughout primary care. Then in, I can't believe it, 2022, I received a phone call from my colleagues at the Canadian Family Practice Nurses Association, as well as Dr. Julia Lukowicz at Memorial University in Newfoundland, and Dr. Maria Poutras at Sherbrooke University in Quebec. And we had the opportunity to put in a proposal for an interprofessional collaborative project aimed at developing a strong nationwide nursing workforce for primary care. Our initial research brought us to the conclusion that pre-licensure training was needed to be a component of getting people ready for primary care. However, that seemed to be a big mountain to climb. And so we looked at post-licensure training that would be aligned with the patient's medical home and the national competencies for RNs in primary care. We realized we needed to address the confusion and frankly underutilization of registered nurses in primary care. We aim to improve the understanding of roles, responsibilities, and the untapped potential of registered nurses as part of the primary care team. This journey included registered nurses working in clinical, policy, academic, and administrative positions from coast to coast, along with our patient partners. Working on a bilingual team across jurisdictions presented us with interesting problems to solve, challenging discussions to engage in, and ultimately a deep understanding of the complex role of registered nurses in primary care. Throughout the project, Team Primary Care kept bringing the component projects or groups to the table to learn more about each other, to provide support to each other, and develop an understanding of how the various professions fit together to provide the complexity of service required of a primary care system. These are the domains that Dale spoke about at the beginning of our discussion today. Just when we were furiously concluding the work supported through TPC funding, we're asked to write a chapter on the registered nurse role in primary care for the TPC Compendium. I will admit to you that initially this felt like an untimely burden as the money was winding down and the work was very, very heavy. However, what we found is that our own understanding of the registered nurse's role had actually clarified through that journey. And we had the ability to describe the complexity and vital role of the registered nurse in primary care in a way that our other healthcare colleagues could understand. The vignettes offered the opportunity to showcase the combination of critical thinking, complex problem solving, and patient-centered care expected of the registered nurse in primary care. The compendium will enable primary care professionals and policymakers to quickly gain a clear understanding of where each profession's role is unique and where it overlaps with other professions, much like a Venn diagram. This will in turn be a valuable resource as jurisdictions across Canada continue to design primary care, from the macro level of policy development to the individual patient care team level. The TPC Compendium will support the development of healthcare curriculum focused on educating a workforce ready and excited to work in primary care. And finally, the TPC Compendium will help the public access supports best positioned to facilitate their unique healthcare journey. I encourage everyone to consider how you can purposefully use the compendium and further who you will share it with, and how you will encourage them to use it. I hope that we can use the TPC Compendium as a stimulus to accelerate the required changes in primary care across Canada so we can realize the goal that I had set for me over 30 years ago. Thank you for the opportunity to participate in this project and share my journey with you today. And I'll hand it back to you, Ivy.
Thank you so much, Treena, Michael, and Derek. That has been absolutely wonderful to work with you. These are, thank you for sharing 3 amazing stories, of which there are 20 or more additional stories, 20 additional training projects. Also, there were team-based training initiatives. And so this was work seeded by Team Primary Care, building on pre-existing work. And it is amazing to see the continued work that is being done. I just want to show you the slide so that you know where to go and get the compendium. Right now, it's available in English, the accessible version. So there's a few tweaks that we need to make to the English version to improve accessibility. So that accessible version and the fully translated into French version will be posted shortly. The URL will be the same. So if you want to click on this, but Raha will also post it into the chat. Just while we have this here, I also want to say it's important to note that there are some elements missing. There were a number of different Indigenous practitioner groups that we hope to include in the version. And I think because there is an actual distinct Indigenous division of labor, there isn't just one group of Indigenous primary care practitioners, but several. And our partners at the Indigenous Primary Healthcare Council are working on those resources. And in fact, speak to it in an article in Healthcare Management Forum that they wrote. Who's also missing are medical office assistants, and I was privileged to participate in a project really looking at their role. So I think, as was the case when the Canadian Health Workforce Network launched the Introduction to Health Occupations in Canada, that was a first edition, and we have since prepared a second edition, and please consider this version a first edition. So any other roles that we should consider, any other feedback, we are absolutely welcome for this. This is not an end, this is just a beginning. And it's a beginning, not just in terms of this as a document, but that we want it to be a living document that gets integrated into education and training programs, as Treena and Derek and Michael have mentioned. So with that, I see that there are additional comments coming into the chat. So I'm just going to stop sharing here so that I can see them. I want to start first with a question and comment from our co-lead, Ivy Anderson, who I believe is actually on a plane. So I will read her question. And so she was asking, how do we share the message that this compendium is not about substituting one role for another, rather to complement? Increasing feelings of threat or turf protectionism is emerging, and it's really important to kind of nip that in the bud through the compendium. So really understanding who can do what, not in a substitutive way, but in a complementary way. So I was wondering, Treena, Michael, Derek, would you, either of you, like to respond to that issue of the complementary nature as opposed to the substitutive?
Sure, I'll hop into that.
Okay.
I firmly believe this is about, in my mind, I see it as such a clear Venn diagram that there's much of what each profession does, which is unique and special, and that profession's the best at. And then primary care has a breadth to it as well, which means we have some overlapping roles. So I actually believe, Ivy, we need to get a better understanding of our own roles and the uniqueness of them, the depth of them, as well as this breadth of primary care. So there's enough work for all of us. We're not going to run out of work.
Thank you, Treena. Michael, I saw your hand. Would you like to respond?
I have to unmute myself. This was very, very interesting, and I'll go back to our pilot project that I was mentioning, because initially, many of the IHPs hadn't worked with massage therapists, and some of them were thinking, well, kind of show me what you do and I'll do it. And as opposed to respecting the scope of practice of each group. And I think working together really reinforced number one, the importance of respecting scopes of practice of each profession, but also the need, the understanding of the value that it brought to the team, because the team was much stronger from a collective point of view. It meant that there was, in terms of literally, like you could say, cost savings, when each team member had the scope to treat what they were expert at, it made the team much more productive. But it also was a way of learning about and respecting the roles of each other. So I think the compendium is very, very important from that perspective.
Thank you, Michael. Derek, did you have something you wanted to add?
Sure, thanks, Ivy. I love Michael and Treena's comments on this. I think what was eye-opening to me when we began to look at the paramedic role in primary care was that it's figuring out that the challenge is figuring out who is best to do what. What you'll notice when you browse this compendium, or if you're familiar with scopes of practice of a lot of these regulated health professions, a lot of us, we use the term, can you do this, or is this in your scope? A lot of us have a lot of that overlapping scope. But really where the winning combination is figuring out how best does the team function when who does what. It's role playing, it's figuring out, and so I'm going to say a sports analogy. I always say sports analogies. This is my life. But if we're composing Team Canada, it's not just figuring out, okay, well, if you can skate backwards, you're going to play defense. No, we need to figure out who the best defensemen are, and maybe you're best in that role. And just because you can put the goalie pads on doesn't mean you should be the goalie. So in team primary care, just because you can do IM injections or you can administer certain medications, the cool thing about all of what I'm talking about is based on the location, the team will look differently, right? There will be team identities for rural and remote communities versus urban centers. So I think Ivy hit this on the head to say, this is all about figuring out, yes, it's not a turf war. We're all working together. Not everyone has to see every patient. And ultimately, how do we best construct the team? And I think this compendium is great to bring all of those roles out for whoever is the architect of these teams.
Excellent. Thank you so much, Derek. And I want to give a shout out to someone who's added some comments in the chat, colleague Victor Perez Correa from Uruguay. So thank you so much for joining us. And I'll bring everyone's attention to those comments in the chat. Thank you for joining us, Victor. On an international theme, I want to now go to Kathy Pecor-Fuller, who asked, is there a connection between this Canadian compendium and the WHO, the World Health Organization compendium on primary care? And so to respond to that, I think I'm going to pass to Dale.
Okay, thanks, Ivy. I did respond in the chat as well. Yes, the WHO document was one of the various documents that we pulled together in the literature to inform both the creation of the domains as well as the services that are provided in each of the domains. So the creation of those primary care domains is a composite of many different sources, the WHO being one. I just wanted to also kind of follow on the comments that Derek made. And I think one of the things in team primary care that we discussed quite often was making sure that we start in the right place in terms of what kind of a team we need and what kind of roles. And that we always start with what are the needs in the community? What are the needs in the patient? What are the needs of the patients? What does your patient profile look like? What does your demographic look like in your area? Okay, great. So we know what they need. What are the various scopes of practice that are available to provide those services? And of course, like Treena said, there's a Venn diagram of overlapping services. And scopes of practice are not just what are your competency within your training, but a various an elaborate scope of practice around what are people's preferences, what are their skills. Maybe there's registered nurses would have a specialty in mental health. Then we start to say, okay, now we know this. Now what can the various team members do? And we mix and match, and that may even change by patient who's providing those services. And so I think that's a really important flipping the switch in a sense in terms of the way we think about planning for health workforce in primary care.
Thank you so much, Dale. Really appreciate that. And stick around because I'm going to be back to you. I actually might go to that message just while you're here. Marissa was asking the domains. Where do those domains exist? What's the plan to mobilize the knowledge that you have synthesized in those domains?
Stay tuned. I think probably, with Sophia at Ivy, they'll want to take a bit of a breath. Now we've got the compendium launched, but the document will be following on in terms of those domains.
Excellent. Thank you so much, Dale. And thanks for that question, Marissa. I'm just going to go back to, Treena, please go ahead.
Hi, thanks. I just wanted to comment about there was comment in the chat, maybe that's where you were going, Ivy, about, how do you deal with protectionism and the funding and those sort of things. And one of the things I think about the compendium is it's a bit of a conversation starter, because this will, as Dale mentioned, it contextually changes over time, because it's not just who's on the team, but who is requiring care. And it's all contextually changing, which means we have to be talking about it all the time, including the things we're uncomfortable with, like money, like power, like hierarchy, those sort of things. And so my hope is that the compendium could provide us all a starting point to have those conversations.
Absolutely. Yeah, a great little quote that we can definitely use when we put things out on social media. So take note, Raha. That's great. Sophie, I think your comments are going to build very nicely from what Treena has just said.
Yes, a little bit of with what Treena said, and also Derek, I think one of the reasons why assembling and curating this resource was so important is, we're talking a lot about scope of practice and extending scope, expanding scope, but optimizing scope. And, there are power dynamics and tensions and turf protectionism considerations for sure. I think one of the really important reasons why we put this together in the first place is we're having a hard time actually optimizing the workers and the workforce that we have in different team arrangements and different contexts. We do a really great job training our health workers and our health workforce. We also do a really good job of constraining them and not optimizing them when we get there. And the system that does such a good job training this workforce actually, in some instances, due to a lack of IPE and IPC in pre-licensure and post-licensure training, the education system also contributes to setting up these workers to fail once they actually enter the workforce and enter into practice and various team settings in different contexts.
Thank you so much, Sophie. And I'm seeing some suggestions in the chat. Thank you so much. Jim, who mentioned pharmacy technician, and my niece, who's a pharmacy technician, would echo that as well. We always are looking for authors. So if you can suggest some authors, please let us know. Julie, you also mentioned kinesiology. Absolutely. They are a regulated profession here in Ontario, and as you mentioned, in British Columbia. So Julie, if you'd like to write a compendium entry or work with someone on that, we also need a chapter in the introduction to health occupations on kinesiology. So please do follow up. I think, Jim, you also had a question, and anybody, if you'd like to ask a question, you could do so in the chat. You can also raise your hand. I'm just going to mention, Jim asked, have you actually attempted to visualize the Venn diagram, especially the overlaps? Well, that's a challenge, and especially to someone who loves doing visuals. No, we have not done that, but thank you for that challenge. If you have any thoughts to suggest, that would be good. Pam, you've asked, is there an intention for this to be a living document that will update it ongoing? Absolutely. This is the first get-go, and it's much easier to update things, to add chapters, to update, as we go. And that's what we found when we did the Introduction to Health Occupations, which is a big mega textbook, of which we have a course that connects with it. And that's something that we would like to do as well. Like, what would make sense in terms of how to integrate this into existing training programs. We're happy to have those discussions and the types of resources. This has been a labor of love with no funding other than little pockets here and there. And so this, we wanted to make sure that this was as professional a resource as possible, so that it's really nicely typeset. So these things do cost money. The translation costs money. So absolutely, we want this to be a living document. We will have to find some source of support in that regard. We'll go to Suzanne. Thanks for this work. Interesting to reflect on. I think it's time to get away from scope of the professional to scope of the team, 100%. And I think Sophie's comments and Derek's comments and Treena's and Michael's comments really speak to that. And, is there a discussion about how power, medical dominance, governance models, and teams is influential? Absolutely. I will point you to a paper that I wrote some 20 years ago on that particular topic. And yes, because it isn't just, and also, work that we did at the Canadian Academy of Health Sciences in 2014, co-led by Siobhan Nelson and Jeff Turnbull, was really about trying to change issues around governance, funding, and education. And so Team Primary Care really focused on the education component, but there could be similar Team Primary Care initiatives that focus on the funding and governance as well. I'll pass to you, Derek.
Great point, Ivy. I just want to chime in something that we never really got to today, but the discussion around practice facilitators is something we're having in New Brunswick. So yeah, it's funding, but then we have to be ready as health systems to, when the policymakers and the elected officials come to us with the bag of money and say, well, what will you do if I give you the money? How do we facilitate the funding? And really that's with practice facilitators and having leaders within healthcare with this mindset that can build these new teams and see that, we're essentially the coaches at this point, and ensuring everyone is playing their proper position.
Absolutely. Thank you, Derek. And again, with the sports analogies. I think Derek and Suzanne and Angela Freeman is also making some comments in the chat in regards to funding and the importance of that. And thank you, Lynn, for adding the CIHC competency framework. We'll make sure that that is also included in the notes of the webinar when we post it to the CHWN YouTube channel, which just adds a little point. This will be posted to the CHWN YouTube channel. Raha will tidy that up and get that up as soon as possible. And please share that with others. And if there are any other resources that you would like us to include in the notes of the webinar on YouTube, please either put them in the chat or send them along to Raha subsequently. So thank you, Lynn, again for that. Cameron, who was on the Team Primary Care project, focused on internationally educated healthcare providers, stated this compendium will be an amazing asset in helping them explore the different roles in healthcare to work to better understanding the provision of care in different Canadian contexts. So thank you for the shout out for that being an important role. And our team at the Canadian Health Workforce Network has done a lot of work with internationally educated healthcare practitioners. And so being able to integrate internationally educated healthcare practitioners to their highest capacity within the system, whether it be in the role that they were trained in or a similar role. I think that's really important. So it was really great to have Cameron and the other internationally educated healthcare practitioner teams part of Team Primary Care. So that has been really great. Here's a really nice question for us to contemplate as a bit of a summary question. Chamanda Swari asked us, what could be the key takeaways from this compendium for, and in the case of Ontario Health Teams or in Alberta for primary care networks, or, you know, the different types of entities that we have. So I'm going to let Derek and Treena and Michael kind of percolate that. What are some of the key takeaways? But Sophie and Dale, and I may come back first to Dale, because I know, Dale, you've been doing a lot of work with OHT. So let's come back to that as sort of one of our wrap-up questions. And then Jana also asked, do we have any recommendations on applying these roles to support the creation of care pathway processes, and which feeds into, you know, the different funding. You know, Derek, you mentioned practice facilitators, and that's really, really important. And lots of other really lovely comments from others, and noting that folks have to leave. So given that we're about 5 minutes to conclude, I'm going to go to Dale first, and then Sophie, Derek, Treena, and Michael, just for some comments about key takeaways before we close things off. So Dale.
Putting on me on the hot seat, but not wanting to end on a negative note. I think it is really important that we recognize that a number of the challenges that have been identified during this webinar still exist out there. And that the first and foremost, professions really don't know what each other does. And they don't know really how to work together and negotiate roles. And the need for facilitators to support those discussions, but also for us to speak about it transparently and honestly about what are the problems that are existing at the coalface in primary care teams, at the OHT level, where this problem exists among primary care teams that are trying to work together. And again, with primary care, trying to work with other partners in the community. So I think the compendium is an excellent start of that conversation to figure out how we can all work together better, but most importantly, how we get to know each other more thoroughly.
Thank you, Dale. Sophie, would you like to add some comments on key takeaways from your perspective?
Certainly. I think not only with the compendium, but even just with the interprofessional collaborative table, as we've emphasized, that this is really a necessary first step. And there were many things in the really robust, comprehensive discussions when we got everyone around the table several times, as Treena noted, that there were some things that we've identified that were outside of the scope of our project, and that we simply just did not have the ability to impact, but are so crucial to this. So, you know, we've talked about regulated professions and regulated scopes a lot. One of the things that might be able to move us in the direction of talking about team scope of practice, which I think is really important, is that we educate professionals predominantly in silos. We also regulate them in silos. We don't yet have mechanisms to regulate team scope of practice and regulate team-based care. So that's somewhere where I think we could hopefully eventually go. And maybe a next step, in addition to sharing this with our network, is to bring educational accreditors and professional regulators to the table, because I think this is a great start. But in terms of really giving this the teeth, it's those individuals in those roles who I can think help us take this next step together. Thanks so much.
Absolutely. Thank you. So an important puzzle piece, but we need other puzzle pieces to create a true picture of team-based care. Derek, I'll go to you for some of your key takeaways.
So for OHTs, I think specifically, within Ontario, I put it in the chat. What's holding up the profession in Ontario is around the absence of regulation, specifically within the community context. So it's an entirely unregulated piece of work for the profession, which is not a good thing. So yeah, for the patient's sake, but also for the profession's sake, if we want consistency of care, we want defined scope, all the things Sophie just mentioned. I love the concept of team-based regulation. However we want to do it, that's, I would say, the biggest. We're moving faster than our foundation is built for right now in Ontario. So that's what I think we need to do, specifically our profession.
Thank you so much, Derek. Treena, do you want to speak to that, but with reference to primary care networks in Alberta and the new Primary Care Alberta?
Sure. So very similar comment that we train professionals to protect our professions. That's part of our training. And we need to move beyond that with some different way of educating and talking about things. And within primary care networks in Alberta, we're undergoing a metamorphosis as our new Primary Care Alberta agency has been stood up, which is very exciting because primary care has a big looking equivalent foothold to other areas in care, like acute care. So hopefully the compendium will provide us in Alberta a equal footing to start this challenging dialogue about who does what best. And I'll leave it at that. Thanks, Ivy.
Thank you so much, Treena. Michael, over to you for your comments on key takeaways.
I wanted to add a couple things to what's been said. Number one, through the work that we did with our project, it was very clear the added value that team-based approach adds. And so as a result, it's really important in that it's one of the solutions to the workforce shortage that we are experiencing right across the country. The second thing was that to points that were made earlier, the need to have embedded into the education with each profession team-based care, because there are power hierarchies, there is lack of knowledge, and so whereas the compendium, and I think is a great first step, I think it has to go deeper than that and has to be incorporated into the training so that you're not trained necessarily, as has been mentioned, in just a silo, but in terms of team-based care and understanding the value that brings and the importance to be trained that way right out of school.
Absolutely. Thank you so much, Michael. And so my role as a moderator is to end on time. I will end with the really wonderful comment from one of our participants, Jillian. Ongoing communication and collaboration is key. Absolutely. Join me in thanking our speakers, thanking all our contributors, and we will have this posted shortly. Please use the compendium. It's very important. Cheers, everybody.